What you're going to see here tonight is a presentation by two very competent and very dedicated hygienists. But you're also going to see a little bit of the story of the practice, because we cannot talk about this subject without talking about things that happened in this practice 20 years ago, or even before that. And the story is about you choosing to dare to be different. Not for the sake of being different, but for the benefit of your patients. So what you're going to see today, 45, 50 minutes, is probably a result of a lot of frustration, a lot of sitting down, studying, and then executing what you think is the best for your patient in many ways until you find what you think is best. And it doesn't stop there. You're going to see that there are new developments, and that never stops. The search for what we think is best for a patient never stops, despite it not being what the mainstream, let's say, literature says. Okay? So a lot of this, or this that you're going to see today, is a result of a lot of hard work and a lot of dedication from people that were here before I was here. I'm just very appreciative that I get to be part of it. And I'm appreciative that you get to see this story. So you're going to see a snippet of something that changed the way we practice in the office today. I didn't see that transition, like I said, but what you're going to see today has changed the way I practice periodontics, in a way that I never imagined. And it has very special people involved. One of them is Dr. Sheldon, the one who kind of broke his head and his brain and picked on and many other people's and many other genius periodontists around the country's brains to but to discover this treatment that we do today. The other one is Rebecca, who's been here in the practice for two and a half weeks, and she's the one who actually perfected the way you use this technology. So I wanted to introduce first Dr. Lee Sheldon to you, and he's going to tell a little bit of the story too, and then we're going to carry on with the night. Okay? Thank you very much.
Thanks, Michelle.
Thank you.
So hi. Hello. This began 38 years ago. So I want you to picture. Wait a minute, how many people were around 38 years ago? A few of you. Good. So Rebecca and I took a trip to Scottsdale, Arizona. This is Rebecca. Rebecca, stand up. Let everybody see you. Because Rebecca's the one who did this program, not me.
That's bad.
So Rebecca and I went to Scottsdale, Arizona, and saw a periodontist named Perry Ratcliffe. And Perry Ratcliffe said, I've got a non-surgical way of treating perio. At that time, we were root plating and then cutting gums. How many people want their gums cut? So we did, I didn't see any hands go up for that either. Gee, okay. So we took a program with Perry Ratcliffe, and Perry Ratcliffe was using retraction cords. Remember the retraction cords you used for crown and bridge? And he was soaking those retraction cords with citric acid and with tetracycline, and that wilted the pocket. And then Rebecca said, I can see the root surface. Now the deal was, I made with my patients, since everybody was used to getting periodontal surgery, I said this. We're going to go for 1 year. It ended up being 8 months. We can go into that later on, but we're going to take 1 year, and I'm going to do nothing but non-surgical perio. Nothing but non-surgical perio. I won't cut gums unless the patient has an emergency, and then of course we'll treat it. And I said, you're going to go through our non-surgical therapy, and if you need surgery, I'll do it at no charge. I did 4 surgeries at no charge in that period of time. Rebecca essentially said, all right, now I can see the root surface. You want to say it, or you want me to say it?
You can say it.
All right, I'll say it. I can finally see the root surface. I can get the root clean. And all of the things that we thought we could do by root planing, we all know there's limitations to root planing until you see it. And then when you see it, you can get it out. So 4 surgical procedures, not bad in that period of time. At that time, I got a little bit excited about regeneration and things like that, so we went back to surgery. Shame on me, I should have kept it the way it was. So that was 1988. By the way, I announced, this was, you know where the mansion is, right? Okay? It was the Strawberry Mansion at that time. It was our Christmas party. We were on the 3rd floor. There was a mouse that was running around the outside of the of the room. But, you know, we had a good time. And at that point, I announced that we are going to do exactly what I said we're going to do. No surgery next year. Rebecca said,
our Christmas party is going to be at McDonald's.
So we went 12 years, and then the Perioscope was invented. We were one of the first in the country to buy the Perioscope, and then we started to use the Perioscope, which is what Morgan and Frank are going to talk about tonight. Visualization. We all know that we can't get down in a pocket and clean a root thoroughly beyond 4 millimeters subgingivally. That's as far as we can go. How do they do that? Maybe you've heard the studies, maybe you didn't. But essentially what they said is to a group of hygienists, one hygienist at a time, scale the teeth as well as you can. We're going to extract them anyway, and then we're going to see how well you did. And 4 millimeters was the rule. 5 millimeters, there was some effectiveness, and beyond that, there was no effectiveness. And that's the problem we have in perio, is getting the root clean. And so the quest was to get the root clean. Somebody invented the Perioscope. Roger Stambaugh is a periodontist, still alive, who developed the Perioscope, and we bought it and we started using it. And at that point, you then start to see the calculus. And then once you see the calculus, now how the heck do you get it out? And so Rebecca would come into my office, sometimes crying, sometimes frustrated, sometimes just talking with me. And how are we going to do it? And as Rebecca said last year, we talked about this. I patted her on the head and I said, go do it. She said, I need more time. I said, take as much time as you want. And she developed the instrumentation and the skills to be able to get the root clean. What was interesting is that I was still doing, we did our treatment, and I would always do a reevaluation, and that usually it would be the reevaluation. I say, good, now you're ready for surgery. But instead I did the reevaluation, and I said, you don't need surgery. And this happened again and again and again. Rebecca was solving all the periodontal problems, all of our patients' periodontal problems in the office. What am I going to do? And so if you want to know the reason why we developed our reputation in dental implants, is because I had nothing to do. I had to learn it. And so we did bone grafting and dental implants while Rebecca handled the perio. There have been lots of developments over the years. And Morgan and Frank were so fortunate to have them, because essentially what they did was to take the techniques that Rebecca developed and added to those techniques. And Morgan and Frank will talk to you about some of the research that's being done, which we can use to get the roots even cleaner. You can never get the root 100% clean. It's how clean do you have to get it in order to be able to achieve healing. By the way, the endodontist will tell you the same thing. They can't get the inside of the root 100% clean. It was something called critical concentration of bacteria. How much do you need to remove to be able to get it clean? And so we're going to talk about not only where we were, but Morgan and Frank are developing new techniques right now to move us from there to here. And with that, I introduce Morgan Savage-Kuntz.
Oh, thank you. Hi. Hi, everyone. Some of you may know me. We're so excited to have you guys here to talk about what we do at Solid Bite. Who has heard of a Perioscope? Raise your hand. Okay, that's good. Who has worked with a Perioscope before? One. All right. When I say this technology changed my life, I'm not joking. When I first applied to Solid Bite, I was like, cool, a perio office. I get to use a laser. And I sat down with the office manager, our Danielle, and she explained to me that no, they have a camera that goes under the gums to see the buildup. And I was like, what? Get out of here. So funny story, first day, or 2 days before I had to train for the scope, I actually partially tore my MCL. You remember that? So I was coming in on crutches, and if you don't know, with the Perioscope, you have to use 2 feet at the same time and 2 hands at the same time. So I was so upset and distraught sitting there watching another hygienist get trained, and the trainer knew. She says, hey, you want to give this a go? I said, yes. No MCL is gonna like take me down. So so we got in there, and I'm telling you, it's like a video game. It is hard. It's hard on the body. It takes patience, lots of patience. But they give us the time needed for it, whether you need more time or not. We usually do half the mouth at a time, just because Rebecca was doing 6-hour appointments, and that's just insane. You're a rock star. I said, not me. Let's do 3 and 3 if that's going to happen.
There we go.
All right, so let's go to the basics. SRP. We are taught in school how to remove calculus with scalers, curettes, ultrasonics, to the best of our abilities. We know that inflammation is caused by calculus and plaque around the gum. The primary goal of SRP is the removal of subgingival calculus biofilm deposits to create a biological root surface and reduce the inflammation. We also know that inflammation associated with periodontal infections affects both the oral environment and the patient's overall health. SRP requires skill, time, perseverance, and patient compliance. All right, so we're going to talk about the toxicity of calculus. Calculus we know what calculus is. Calculus is calcified dental plaque composed primarily of calcium phosphate mineral salts deposited between and within remnants of formerly viable microorganisms. But we found out that there are 4 studies that show that sterile calculus actually causes inflammation. They took calculus, put it in an autoclave, sterilized it, put it in some guinea pigs, oral cavity, and notice that the clean calculus causes inflammation. So what does that inflammation do? We know it links to systemic diseases. Microislands of calculus. So when I worked in a general practice, I'd get for SRP, I'd get 2 hours for half the mouth. I'd do the best I can, remove everything. I'd go in with my 11-12 Explorer, feel. I'll take some post-op bite wings. Don't see nothing. All right. And I go home. I could sleep at night. Patient comes back 3 months later. That 9mm pocket is now a 7mm pocket and bleeding. Okay. I'm going to get in there real good this time. Maybe irrigate it with some chlorhexidine. Bring the patient back 3 months later. Okay, it's about a 5-6mm pocket. All right, maybe I'll place a little Restin. Maybe that'll help. Maybe there's bacteria in the pocket, right? And patient comes back, it's still about a 5-6. All right, well, Mr. Smith, we're gonna maintain this pocket. It's a 5-6. Hey, but it was improved from a 9, but it's still bleeding. What's going on? What's happening here? Again, microislands of calculus. Microislands, Dr. Sheldon calls it microislands. I call them micro mountains, but he says it's okay because they're both vacation spots. What are microislands? Microislands of calculus are areas of calculus left on a root surface that prevents a pocket from healing. Let's say that again. Microislands of calculus are areas of calculus left on a root surface that prevent the pocket from healing. Okay? So here is a video. Can we dim the lights a little bit? Of a great representation of Dr. Sheldon talking about microislands.
So this is the root surface of the tooth, and what you're seeing is the root surface, and you're seeing calculus right there. Oh, I already drew it in. All right, good. So let's take a look at this sample right here, and let's look into the calculus. And what you're looking at is spaces between the calculus. So picture a piece of Swiss cheese. And this is, you're looking at the hole within the Swiss cheese. So there's the hole. And what I'm going to do is locate for you all the bacteria within this small hole that you could not see with your naked eye and couldn't even see with a regular microscope. This is an electron microscope. And there's bacteria within those spaces. Unless we get that calculus off, that bacteria remains. You can't just smooth that calculus off, because as you smooth that calculus off, there's still holes with Swiss cheese in it and still bacteria within it. Let's look at an area of calculus. Now what you're going to see to the right side of your screen is the calculus. That's the calculus there, okay? I just colored it so you could all see it better. And on the left side of the screen is the root surface. And I want you to notice right here what's there. A little finger projection. Essentially what's happened is the calculus has eaten out a space. The calculus actually drilled a little hole into the tooth so it engages into the root. It's holding on to the root real well. So here's Morgan, and Morgan goes in and she says, okay, I've got this tooth. I'm going to go in there, and I'm not saying this is Morgan. I'm going to say any hygienist, not Morgan. So there she is with her Cavitron tip, and she goes in with her Cavitron tips, just zzz, 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 and what happens? Oh, a piece of calculus flies out. Oh, am I happy? I got it. Oh, I got a big smile on my face. Except what's really going on is this. Bzz, 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 bzz. Gets loose, comes out, zzz. And look what's left. That's fractured calculus. In other words, the calculus doesn't come off the root, it breaks within itself and always leaves, or almost always leaves, residual calculus in there, which has the same Swiss cheese opening, which has the same bacteria, which has everything that's bad. So now you look with the scope, and now Morgan discovers, I'm picking on you, why not? Because you came from one environment and you moved to this environment. And I bet you, Morgan, when you started, you weren't sure this was the right environment for you, right? Okay, maybe. That had to do with the environment that you came from, okay. So, but it's discipline, and take a look what happens. So we have this fractured calculus. Now Morgan tries to do the best as she can, or any hygienist tries to do the best as she can, and she goes in there with a curette. And she engages the calculus, and she pulls up, and she gradually removes what she thinks is the more calculus that's left there. And she smooths the root and even tries to get rid of that finger and gets rid of that finger along the way and does root planing. Except what remains? The fractured calculus is still there. So now she goes in with a scope. And now she can discover with the scope what's there. And now either inspecting the scope with a two-handed technique or with a single, all right, now I know where this calculus is, now let's go and get it off. Then she comes in and then she removes the calculus. She'll start with an ultrasonic scaler, and then she may move to, and she'll likely move to a hand scaler. We want to do ultrasonics as much as we can. Not that ultrasonics will do the complete job, it won't. But at least we're doing the bulk of the work with the ultrasonics, which is easier on the fingers. But then she goes back in and she still sees there's some residual calculus left. there's always residual calculus left. We're trying to reduce the concentration of the calculus enough that the body will heal, but because of those projections, those finger projections that are in there, there's always going to be a little bit of calculus left. Our goal is to reduce the calculus enough that the patient will heal.
The patient comes in for a new patient appointment with Dr. Sheldon or one of the Dr. Furtado, and they probe and discuss what type of cleaning the patient's going to need. We also identify bacteria by using oral DNA testing, which we'll talk about that. And then, because in some cases they'll need antibiotics to help remove systemic bacteria throughout the body. And then afterwards, we also help them, with their adverse health factors. We look at their airway for sleep apnea. We do smoking cessation or OHI. And then they'll come to us and we remove them with the scope and Pref Gel, which we're going to get into that. And then we bring the patient back 6 to 8 weeks later, do another oral DNA test, probe, see where the healing's all at, and then set up their recall, which is every 3 months. So here, I don't know if anybody's familiar with an oral DNA test, but we have 700,000 of bacteria in the mouth, but we test for 11 specific bacteria, which you guys know, some AA, PG. So you have high-risk pathogens versus low-risk pathogens. This black line is a threshold. We want their bacteria below a certain threshold. All right, so when we send this report to the oral DNA lab, they kind of come back saying, okay, these are the bugs that are kind of going crazy, and this is the antibiotic that we recommend. Well, and there are some bacteria that metronidazole helps, but then Dr. Furtado will look and say, well, this person has PG, so, amoxicillin is going to help this case as well. And sometimes we also give 2 antibiotics in a case just to tackle different bacteria. And we also want them to preserve their microbiome, so we tell them to take a probiotic. Again, these are in more severe cases. And sometimes I see them, we'll have them started a day before, and already their pockets are reduced just by taking the antibiotics. So you can hit it. So this is just a close-up. The lab will also say, that, they even say scaling and root planning is, helps disrupt the biofilm and remove plaque. But this patient harbors this bacteria and it may refract this treatment. So that's why they need this antibiotic. Okay. So then when the patient comes back for their post-op and we do a second oral DNA, we test to make sure that these bacteria are below the threshold. Sometimes they might be a little wacky with the PG or something, and maybe a couple still hear spots of pockets, and Dr. Furtado will do like another couple days round of antibiotics and bring them back in 2 weeks and check the pockets. But it also gives us a reduction of bacteria, of how much that's going on. Okay. What's also cool, so I print this whole thing out for my patient. It gives them the systemic links to which bacteria links to what? Cancer, cardiovascular disease, arthritis, dementia. So, if somebody has a high PG count, well, PG is in cancer and cardiovascular disease and arthritis. I say, take this to your doctor. Oh, well, I have heart problems. Yeah, take this to your cardiologist. Just kind of shows them what's going on. So now Frank is going to talk about what a perioscope is.
Who has had the chance, I'm getting over a sore throat, so who has had the chance to actually see a perioscope? 1, 2, excellent. All right, so what's a perioscope? A perioscope is a fiber optic technology that makes it possible for hygienists to be able to see and gain access to plaque, and calculus under the gums. All right, so basically the perioscope is a tiny camera, this part of the unit, that lets hygienists have a new vision of your root surface and remove all the hard deposits in 4 or higher millimeters pockets. All right, so the loops that we tend to use in the office, they have 3 times, 5 times, depending on how much you invested on them. So the Perioscope actually magnifies from 45 to 50 times what you can see down by the pocket. Get it? All right, so in school, we're trained. How do we tell that there's cochlus? Well, we can use x-rays by wings. If it's too much, we can see it even in a panel. But basically, it's the tactile exploring. And traditionally, periodontal therapy has been performed by effective plaque control and mechanical therapy by scaling and root planning. The efficiency of the treatment depends on different factors, like the anatomy of the subgingival area. We know about the first maxillary molar has very interesting roots. Also, the palatal roots of the maxillary molars are tricky spots to get. Sorry, this ends. Normally, the examination of the treated site is accomplished by manual and tactile exploration. However, the inability to detect some root deposit that had not been eliminated has been repeatedly demonstrated by different investigators, Rager, Gavani, Sherman. In our practice, we believe that with full removal of the cochlus surrounding the root, we will gain more tissue attachment and prevent the patient from needing invasive surgery. All right, so here's an image of the Perioscope. Here's the pocket. So this is for anyone who hasn't seen it or is hearing for this the first time. Visualization and tactile perception are the most important diagnostic tools for recognizing root wall cochlus. Scaling and root planning have long been dependent of the operator ability. That ability you get, you're starting school, but then when you learn it in the practice, by doing cleanings, SRP, every single day, every single week, months. The Perioscope can help enable visualization of the location, the amount, the density, and the shape of subgingival cochlus, adding the reduction of the residual cochlus. Scope can also see the fit of restorations, cement around crown margins. Sometimes we see some crowns and we know that that cement has been there for 10, 5, 15 years. We can see root fractures, subgingival caries, broken instruments in the bone or pockets. You had a patient that had a lot of cancer treatment to his neck.
Yes, so just very quickly, he came in for one tooth. He's been going through jaw radiation and cancer treatment. And we were supposed to adjust the bite as well. And so it was number 20. I had to go on the lingual. He had 9s all on the lingual. Very inflamed and everything. I go in, I'm not seeing anything, but wait, what's that? Something's floating literally around it. It is a part of his bone that was floating because the patient was biting so high on that tooth that he literally broke the ridge of his bone. And I was like, oh, okay. So we adjusted his bite, got it all. Dr. Furtado made me chlorhexidine and, remove the piece and everything. So, and he's doing really great.
All right, so these are the parts of the Perioscope. This is the fiber that you connect to the unit. Actually, this tip is what's going inside the pocket. If you ask yourself, how do we use this, not contaminating it from patient to patient? This is a disposable, what we call the sheet of the sleeve. So this goes here inside. When you finish with the patient, this gets discarded. This one, the Perioscope uses water. So for me, it wasn't that hard because I play the drums. Because now you're gonna have to learn to use the
Yeah, show off.
with one pedal. You're gonna use the Cavitron, and then with the other pedal, you're gonna use the Perioscope. So at the beginning, it's really, really, really hard. I had a wonderful teacher and trainer. When she was training me, she was telling me, more water. And I was listening, more water, but I wouldn't do a thing. she would
Like, more water.
she would actually put her foot on my foot.
And I go,
more water, I said. So,
oh, there it is.
click it. So these are the inserts, and the manufacturer or the designer, they have certain recommendation, or they want you to use them in a specific way. Then you get to use, go back.
Oh.
Then you get to use them like you want. For example, let's say, notice that this one has one, this have double. So this one are supposed to be used in the distal of molars. Personally, I really like using this one in defurcations. In defurcation involvement, 5, 7, 8, 9 millimeters. With this ones, I feel that I can see everything. With this one, not so much. Click it. All right, so here's some recommendation of how to use them. So the yellow one, we work with sister surfaces. So here, what you can use in the buccal or facial, you're gonna use on the lingual of the other quadrant. Here, on the lower, what you use on the buccal, you're gonna use on the lingual of the other quadrant. Same thing with the red one. They somehow recommend the red to be used more in the anteriors. One thing that I learned from the Perioscope is how bad I was doing cleanings. Because sometimes you have a patient that is for, we don't use the term full mouth debridement, but you clean everything, you have your loops, you look, it looks good, but then you take the scope and you go down there, it's like, oh, I left all that, and you go and remove it. Click it one more time. Same thing. More indications of how to use this, double strip. So you notice that one had one strip and the other one has, that's how we tell them apart. Click it one more time. This is one of my, I don't know if to say favorite patient or
Your
proud.
best result.
What made me the most proud. This patient, I think he hadn't had a cleaning in 15 years. At some point in his life, he had ortho. You see the bicuspid removed. When he came to the office, he had already lost 24, it just fell off. You can see that he has 7, 8 millimeter pockets. This tooth at the beginning appointment, it was completely hopeless. It was not pro because it was completely covered. It was a wall of calculus, not able to probe. When I get the patient, I noticed that the enamel and the dentin is so healthy. It's pretty. Then I asked the permission of the doctors, hey, can I try to save this tooth? Its treatment plan for extraction has not been probed. To mobility. And then after April this year, after 4 hours of perioscopy, these are the pocket depth. Now here you can see the attachment loss. That tooth still reserved prognosis, 4.55 attachment loss, but look, I have 1 millimeter pockets.
And it's really not mobile. We just didn't change that as well.
Yeah, sorry.
So.
No 7s, no 8s. Could you go back for a second so they can see it one more time? 7, 8, 7, 8, 8, 8. Forward one more time. So it's complete game changer.
It's probably hard to see in the back, but.
Well, there were 7s and they're not anymore. Believe me.
Yeah!
One thing I want to add is that seeing her doing this, I was almost 3 years ago, I was temping in the office and I go walk into my op. It's like looking at a Star Wars movie. Like she would be going with a lightsaber because that's how it looks. Not the Sith side, the Jedi side, because it's green, and I see her like all the room black and a green light coming from out of the mouth of the patient, and I'm like, "Are you putting a camera inside of the patient's mouth?" She's like, "How cool!" And here is some of the results. I think the next one is you.
Okay.
Oh, something I wanted to add. So while I was being trained, we were not doing this. So I was trained the traditional way. Right after I was trained, before I was thrown to the wolves, Dr. Lee had an idea based on his research, and here's Morgan to talk about, because she has the experience of working with before and working with. I'm the new generation, even though I'm from the 80s. I know how to do the scope with this, so.
All right. Thank you. All right, so Dr. Sheldon came to me one day, walking through our really tight hallways. He says, Morgan, I've got this great idea, and we're going to use it during the perioscopy procedures. It's going to be a big deal. We'll talk next week. And he walks away. I was like, okay. So the next week, Dr. Sheldon sits Frank and I down and starts talking about Pref Gel, which is another name for EDTA. If you don't know what EDTA is, it's a form of an acid, but they've been using it for many, many years. Endodontists use it in root canals to clean a calcified canal. Dr. Furtado uses it during his gum surgeries. He'll flap the tissue back, clean the root surface, put some Pref Gel on, rinse it, close the flap, make sure that it's all clean and smooth and has no debris on the root. So Dr. Sheldon came to us and said, hey, 3 of my buddies, his perio buddies, decided, why not try this in a pocket? Maybe this will help with some micro islands of the calculus. So they even did an in vitro study, which is outside the mouth, that reported that the use of a 24% EDTA gel following SRP appeared to significantly alter the physical properties of the micro islands of calculus. We have the articles here in case anybody wants to take a glance at them. So how do we place the Pref Gel? Can you go back to the last one?
Of course.
So it comes in the syringe. The syringe, and it's very inexpensive. The syringe come with tips that are easily mandible, and you place it in the pocket. Go to the next one. Use a very thin micro brush, graze the pocket for a minute, and then rinse. It's very important to rinse the pocket. I even go in with a Cavitron at the end just to make sure I'm getting underneath there to rinse it. And the blessing of this is that you can place it anytime you want. So the first time I used it, I had a patient that had not super deep pockets, about 5-6 millimeters posterior, but heavy calculus. And I said, let me just place it first before I start going in there and cleaning. So I place the Pref Gel, I go in with my scope and my Cavitron, and boom, boom, it's just popping off. And Dr. Furtado walks by, and I was like, Dr. Furtado, get in here. He's like, what? I said, where has this been all my life? It came off like butter. He's like, I don't know, I just never thought of it. And so and then another thing too, if you have a tenacious ledge of calculus on the lingual of your anterior, you can place it there, leave it for a minute, and you'll just notice it's so smooth, comes right off. Yeah. And another thing too, another area you can place it, let's say you go in and clean. I like to kind of clean the patient first, then go in with my scope and see, how great I did, right? And the areas that I miss. But then after you clean everything, you'll go in with the Pref Gel and graze the root just in case, and rinse it really thoroughly and see. And the results we're seeing are outstanding. We haven't had one negative case, one negative downfall, any complications. So we're going to show you some pictures of what our Perioscope can do. So Amanda Clark isn't here, but this is one of her patients. This is a patient that came in with severe perio back in 2021, and this is her in 2022. So the bone doesn't really deteriorate away. It just becomes radiolucent, and then it becomes more dense again once all that bacteria is removed. This is the same patient. You can see the difference here on the tooth, on that root. So this patient is actually one that made me a believer. I hadn't been able to train on the scope yet, but she came in for a perio maintenance with me, and I saw her pockets before. But on the distal of number 8, she came in with like a 10, 11 millimeter pocket. And now that is a solid 2 being held in by the gum. And it's still to this day. That was in April. I took a post-op and I just want to see what was going on. And she's doing really good at her home care. And that's another thing we have to emphasize, that oral hygiene is so important or they're wasting their money. All right, so this is a great case. She came in back in November of last year. You can tell she's got severe perio, furcation involvement, all the molars, but she's had SRP done 4 or 5 times in her lifetime. So she's a very good cleaner, but she's a smoker as well. She's a smoker. And so we decided to do 4 hours of Perioscope. And this was her pockets before, so if you want to go to this one. So these were her pockets. You can see she's got 9 furcations on the lower right, a bunch of 7s. Again, just most, 8s in the furcation here. Again, 7s. She's got really good home care, but she needs some help. Why are those 7s still there? So we did 4 hours of, probably back in like April or so. All right, so this was her before with some 9s and 7s, okay? I did 4 IP, I did a 4-hour cleaning with the scope. Now go. So, patient came back for her follow-up after her 4 hours of just the scope. Dr. Furtado, we probe her. She's still got some 7s. I mean, we have some healing. The 9 is a 7, but she still has some 7s here on the lingual. 6s, 5s, 5, 6, 7 on 15 buccal. He says, I think we could do better. Let's just do another 2 hours with the scope, see if we can do any better. Well, at this point, we are implementing the Pref Gel. All right? So she comes, wait, just a second. So I clean her, and I can't see nothing with the scope. Nothing. Usually when we go in, the calculus with the scope lights up gold. It's like a video game. It's really cool. You'll see a little video at the end. But I couldn't see anything. Nothing's shining bright at me. Her plaque control is great, and I said, I'm just going to Pref Gel the crap out of her and see what happens. So I Pref Gelled her everywhere, and this is what we got. Couple 5s. She's got that 9 is now a 5 on the lingual of 31, and a 4s, a couple of 5s. And it's just amazing. All mobility is good. All right, so we're going to show you kind of a video of me, placing the Pref Gel and using the scope at the same time. So there's 2 ways you can kind of use the scope, like Dr. Sheldon was saying. There's 2-handed technique, which I don't know how some people do it. Amanda would do that. Would go with the scope, pull out, clean what she can see on the scope, then go back in with the scope and see if it's gone. I can't do that. You'd be surprised the ways we use the Cavitron itself and the angles that we go at. It's not just right at that line angle, straight up and down. It is left, right, side, in front of the scope. I think the hardest parts that I notice is that we as hygienists miss are line angles, interproximal, right underneath the contact. It's always going to be right there. And obviously furcations. You think you're getting that buckle like it's a class 1 furcation. You think, okay, I'm grazing that little indentation. No, it's still staying there. So again, that's what this lights up. Hi, I'm here today with my patient Robert, but we're going to be doing number 31 implant. I have a pedal on my right foot for the scope and a pedal for my Cavitron on the left. You can always alternate left or right. And then I have one hand my Perioscope insert and then my Cavitron tip. All right. So we're going to go in here. And as you can see, I'm going to be spraying some water here. And when you see it light up gold, that is the calculus. You okay, Robert? Mm-hmm. So it sprays water to remove debris, and so this is my insert here, and then this is the tooth, the implant itself. Yeah. We're good. Close. As you're in there, and then I come out and I'll go more mesial, and now I'm on the distal of 30. Back to that area. And that's right under the crown margin, a little bit of buildup. But he's getting a new crown. All right, so now we're going to be placing some Pref Gel on Robert. It's another name for EDTA. On number 30 lingual, on 31 implant on the lingual. So I'm going to take a micro brush and put a little bit on the tip of the micro brush. We're going to blow some air on the area. I come in with the gel, and we're just going to kind of apply it to the area for about 30 seconds to a minute, sub. I'm even going to hit the distal of 30 itself. Put that in there in the mesial of the implant. And I'll even go in with my Calitron just to go sub below it and get any residual. And that's how to use Pref Gel. Feel free to answer it, but again, there's kind of limited areas of where you can actually purchase a Perioscope. PerioView is another brand that you can look into as well. And who are we ending it? So that is it.
Thank you.
All right. Any questions? Okay.
What year did this come out and how much did the Perioscope cost?
You want to talk? Did you hear what you said? Do it again.
Yeah, I just want to know what year it came out and how much does the machine cost? How much does the Perioscope cost?
The Perioscope came out around the year 2000. It might be 1999. The Perioscope itself was bought by, went to the fourth company. The fourth company is discontinuing making it right now. And so the new scope that's developed by a periodontist, Dr. Aziz Bora, in Phoenix, Arizona, and we just checked on the price, and the show special was $33,000.
Okay. Thank you.
Any other questions?
I wanted to talk about the DNA test.
Yeah.
So you mentioned that you guys do the oral antibiotic based on the test for the saliva.
Right.
So whenever you guys test for the saliva and you send it to a lab, how long does it take for you to get the results back?
Like 2 weeks? 2 weeks.
What was her question?
How long does the results for the oral DNA come back to our office?
Do you
About 2
guys
weeks.
charge extra for that? To your
Yeah, almost the value of what we get charged from the oral DNA.
Yeah.
Okay,
Yeah.
just to get that back. So it takes about 2 weeks.
Yeah. No, so we try to tell them,
What was the question?
do we do some,
Where are you getting the sampling from? Where are we getting the sampling from in the oral cavity? But like just this, like no, not any specific site.
no, just them spitting in the cup.
Just like the
We'll probe them, activate the kind
ancestry.
of the bacteria count. We even have a microscope that Dr. Sheldon uses and kind of shows the buggies and going crazy in the mouth, which people freak out about. That's always a good tool. But yeah, it's just them spitting. We try to remind them when they're coming back for their follow-up not to rinse or brush their teeth beforehand so that it doesn't, alter the test result.
Where are you getting the Pref gel, and how much is that, a syringe, or however
it's
it's
like
sold?
15. Yeah, here, he's got that one.
Pref gel comes from a company called Strawman. Pref gel is the root preparation. EDTA is the root preparation for a regenerative product called Emdogain. And so we buy this directly from Strawman. It costs, you saw the syringe that Morgan was showing. That costs $15 per syringe. And how much can you get out of a syringe? How much amount?
I mean, I use one syringe maybe on 4 or 5 patients. So, because it really goes a long way in each canal. I mean, if they have severe and I want to go back in a second time and everything, I'll probably use one. Frank likes to use a whole syringe on somebody. So, anyone else?
When you say you're doing 4 hours of root plan, that's the one appointment. You're sitting there for 4 hours with one patient?
No, if it's 4 hour, I mean, that's very rare, but we usually do half and half. So 2 hours for one side and 2 hours the next.
3 hours for a side.
Or we do 3, like if it's a 5 hours, the doctors determine how long it's going to take us versus how much buildup, pocket depths, whatnot. And we'll do 3 hours one visit, 2 hours the next, and we'll kind of pick the quads that are less invasive or, less buildup and do that the 2 hour one versus the 3 hour.
And if the patient needs more time, we don't charge for the additional time. It's what do we need to do to get the best result possible?
Well, with introducing the Pref gel, does that reduce your treatment time?
Yeah, I mean, that's very good. For right now, though, it's still in the experimental stage. So, but it does significantly remove it. So, yeah.
Like butter.
Like butter.